Hey everyone, welcome to The Explainer. Today, we are diving headfirst into the ultimate high-stakes survival guide for critical care. If you've ever felt completely overwhelmed by the sheer volume of information needed to keep a critically ill patient alive, well, you're in exactly the right place. We are going to decode the complex pathophysiology of shock, unravel the mysteries of the heart's electrical system, and give you the rock-solid knowledge you need to respond to life-threatening cardiac emergencies.
All right, here's the game plan for today. We're going to move step by step through 1. The stages of shock. 2. Hypovolemic versus cardiogenic shock. 3. Conduction and EKG basics. 4. Managing dangerous cardiac rhythms. 5. Cardiac arrest and CPR. And finally, 6. Essential pacemaker principles. Let's get right into it.
Section 1. The stages of shock. You know, shock is really a downward continuum, happening in 4 distinct stages. It kicks off with the initial stage, which, honestly, is incredibly subtle. Your patient's body shifts to anaerobic metabolism, kind of like the cells are gasping for air, and that leads to lactic acid buildup. If we miss that, they slide right into the compensatory stage. The body's fighting back here. Vasoconstriction kicks in to keep that blood pressure stable. But if those mechanisms tap out, boom, we hit the progressive stage. This is a massive red flag. Blood pressure drops, perfusion just plummets, and hypoxic injury happens. Finally, if it goes unchecked, we hit the refractory stage. At this point, the damage is literally irreversible. Organs shut down, and the body just stops responding. So, what's the big takeaway early on? A serum lactate level greater than 2. That number is a huge red flag indicating worsening tissue hyperperfusion. When cells don't get enough oxygen, they panic. They pump out lactic acid. So that 2 on your lab results, yeah, that's your early warning siren. To confirm just how badly the body is struggling, we look at baseline ABGs versus uncompensated metabolic acidosis. In progressive shock, you're going to see that uncompensated metabolic acidosis. The pH drops below 735, the bicarb falls below 22, and that CO2, it spikes above 45. The body is just overloaded with acid, and the lungs and kidneys simply cannot keep up the balancing act anymore.
Section 2. Hypovolemic versus cardiogenic shock.
Treating shock definitely isn't one size fits all. Think of the cardiovascular system like plumbing. Hypovolemic shock means the tank is empty, so you treat it with oxygen, aggressive IV fluid resuscitation like a 30 milliliter per hour bolus, blood, or albumin. Cardiogenic shock, though, the tank is full, but the pump is totally broken. Giving fluids here would literally drown the patient. Instead, for cardiogenic shock, you need pump support. We're talking meds like norepinephrine or dobutamine. Speaking of dobutamine, it's an inotrope. That's a medication that specifically increases myocardial contractility and stroke volume or cardiac output to fix that failing pump. Think of it like a chemical adrenaline shot right to the heart muscle, making it squeeze harder to restore perfusion to the body. All right, so we've stabilized the fluids in the pump. But what if the electrical system fails entirely? Without that electrical signal, the pump has absolutely no clue when to squeeze. Section 3. Conduction and EKG basics. Let's trace that electrical spark. It fires first at step 1, the SA node, down to 2, the AV node, then 3, it shoots through the bundle of His, splits into 4, the bundle branches, and finally cascades across step 5, the Purkinje fibers. Every single step of this pathway has to fire in perfect, precise sequence. And what's really fascinating here is the precise timing required. A normal P wave is a quick 0.06 to 0.12 seconds, or 1.5 to 3 boxes. A crisp QRS complex should measure just 0.06 to 0.10 seconds, which is 1.5 to 2.5 boxes. And the T wave lasts 0.10 to 0.25 seconds, or 2.5 to 5.5 boxes. If these times stretch out, you instantly know you've got a block or delay somewhere. Now, if a patient is suffering a massive STEMI, you absolutely need to know which 12-lead EKG leads are affected based on the location. Memorize this. Inferior damage shows up in leads I, 3, and AVF. That is a highly testable, real-world lifesaver. Anterior damage presents in V1 and V4. And lateral wall damage? You'll see that in leads I, AVL, V5, and V6. Section 4. Managing dangerous cardiac rhythms. When normal sinus rhythm breaks down, you gotta act fast. Take SVT, for example. You must instantly distinguish between stable SVT and unstable SVT. For a stable patient, you assess, get a 12-lead EKG, try vagal maneuvers, and do a rapid IV push of adenosine. But if they're unstable, we're talking immediate cardioversion to shock that heart back into rhythm.
But hey, we can't just treat the rhythm, right? We have to find the root cause. If a new dysrhythmia pops up, rapidly run through these reversible causes, the famous H's and T's. We're looking at hypoxia, hypothermia, hyper or hypokalemia, hydrogen ions, meaning acidosis, hypoglycemia, and hypovolemia. For the T's, check for tension pneumothorax, cardiac tamponade, toxins, trauma, and thrombosis. Fixing these is usually the only way to get things permanently back on track.
Section 5. Cardiac arrest and CPR.
If things deteriorate into a code, there is zero time for second guessing. You follow the cardiac arrest protocol perfectly. Ensure the scene is safe. Recognize unresponsiveness and absent breathing. Check those pulses. Activate the emergency response. Initiate high-quality CPR and immediately attach the AED or defibrillator.
Once those pads are on, the monitor dictates your path. You've got shockable rhythms like VFib and pulseless VTAC, which require immediate defibrillation. But then you have non-shockable rhythms like asystole and PEA. For those, you never shock. You keep up the CPR and you push epinephrine to try and chemically jumpstart the system.
Section 6. Essential pacemaker principles.
For patients with an artificial electrical safeguard, EKG pacemaker assessment is key. You're looking for very specific lines. Look for pacing spikes right before the P wave, which tells you the atria are being paced. And look for spikes right before the QRS complex, meaning the ventricles are being paced.
But these devices aren't perfect, and you absolutely must learn to spot these three major malfunctions. First, failure to pace. The expected pacing spike is just totally absent. Second, failure to capture. The pacing spike appears, but it is not followed by a P wave or QRS complex. The stimulus just wasn't strong enough. Third, failure to sense. The pacemaker fails to detect the heart's intrinsic activity and just fires inappropriately.